bile acids, cholesterol, phospholipids, and proteins. Okay. Bilirubin is the breakdown product of heme and then is excreted as bile. Okay, so this is why when we look at total bili, conjugated bili, direct, indirect bili, it all has to do with the breakdown of bilirubin, where it is. I'm not going to make you know all of those things. You already learned all that, okay? But we'll need to know certain levels of certain labs when we get there. All right. Liver is one of the main sources of where glucose is processed, where we get our energy, okay? So if we don't have a functioning liver, a lot of times we have fatigue, we have malaise, we have other things going on. So when you have fatigue, you have to look at the liver, okay? Another big one, the biggest one, is metabolism of fat-soluble vitamins A, D, E, and K. So vitamin K, you have all those clotting factors that are dependent on vitamin K. Right? So if your liver is not working correctly and not metabolizing vitamin K correctly, you are going to be at a bleeding risk, right? You're going to be coagulopathic. All right, so what do we do to look at it? We can ultrasound it, evaluates the biliary tree, evaluates the contour, evaluates the tissue itself, whether it's heterogeneous, whether there's lumps, there's cysts. Okay, ultrasound is great. CTs and MRIs are also very good at detailing those muscle structures or the tissue structure. Okay, we can also do nuclear medicine scans. We can do angiographies. We can do biopsies. But most of the time, we start with an ultrasound and then a CT, and then if we really need to get really, really fine detail, then we'll go an MRI. Okay. So, liver trauma. Most commonly injured solid organ in blunt trauma. Okay, it takes up a big part of our abdomen. Okay, so when we have a blunt trauma to our abdomen, it gets hurt a lot. Also doesn't like to move for penetrating trauma, so it's frequently involved because it's big. When you get big, when you have a big solid organ, most likely it's going to get hit. Common sense. All right, clinical presentation, you're going to have abdominal distension, pain, tenderness on exam. I had a guy, I had a mass casualty incident at Lejeune, and he was in a rollover. It was a big thing a few years ago. Anyway, he came in and he was a walking wounded, he was green, and I think I told this story already, but basically he only had a little bit of belly pain. Right? No bruising, nothing ran over his belly. He just had a little bit of belly pain. I was just gonna, say, well, you probably have abdominal pain. This is the trauma surgeon said, well, let's just be safe and get a CT. He had a grade 3 liver injury, so he stayed the night for a couple nights. Okay, so any sort of blunt trauma to the belly, you have to, and there's pain, you should always evaluate. Okay. All right. What are the complications we can see with liver trauma? You can have a biliary fistula, it's the most common sequela. Okay, we have biliary tree, which we'll see in a few slides when we start talking about biliary stuff. Is that it all starts, these biliary tracts go out through the entire liver. Okay, so if you have an injury in a liver, you can have bile leaks. Okay, so when you have this fistula, basically it's just, it didn't heal correctly and you just have bile leaks into the belly. Okay. Arterial aneurysms, any damage to the arteries, you can have, they're really, the potential for rupture is there, okay? And most of the time we just manage those with the angiography and embolization of those arteries, okay? And then we kind of talked about pneumobilia yesterday with the gallbladder, or the gallstone ileus. Okay, you can get those from a bunch of different things. Rare with trauma, but if you have any ischemic bowel, gallstone ileus, necrotic gallbladders, basically anything that could be infected with gas-producing products. Okay, if they've had an ERCP, you're going to have air up into the liver. You're going to do pneumobilia from that. Okay, and this CT below kind of shows that error within the liver. All right, biomas. So you had those fistulas, but now it's a collection of bile. It's not just leaking. Now you have a bioloma. You have an actual collection, kind of walled off of bile. Okay, most likely they're small. Most likely they're sterile. Most of the time they reabsorb on their own. If it's a larger collection causing issues, we can drain it percutaneously. If it becomes infected, most likely after penetrating trauma, like the things that, you know, knives and bullets are not really sterile, so if it goes through our belly, the risk of infection goes up. Okay. Treated like any other intra-abdominal abscess, so most of the time we will drain it. If it's bad enough, we will go in and try to clean out the belly, wash out the belly as best as possible. Which then gets into abscesses, okay? We can, so you have the liver up here, right? All this dark area that's next to the ribs, okay? All of that is blood, most likely blood, okay? All of that will most likely get reabsorbed, but it could become infected depending on what caused it, okay? If it was a penetrating trauma, you have that chance of infected material or bacteria getting into that, and it could become infected. Most of the time we will put drains in that and try to drain it as much as possible without having to open. But if we need to, we will. Okay? Use your bedside ultrasounds liberally. Okay? If you have major leaks, then we'll do an ERCP, and most likely a sphincterotomy is a sphincter of Oddi, which we'll talk about. Okay? Minor leaks most likely can just be observed, and most likely conservative management. It depends on how, kind of like where they are in their process. Okay. All right, liver masses. Okay, there's a bunch of different liver masses that we're going to talk about. So we're just going to get through. Okay, so first are cysts. Right, the simple cyst is the most common. It's smooth, it's contoured, it's got anechoic, meaning it doesn't cast shadows. Okay, it's fluid. Well-defined little circle. Okay, smooth, asymptomatic. Cyst requires no treatment. When it does become symptomatic or if diagnostic, like you really just don't know, you really want to check, then you can have IR go in and do needle aspiration and serology testing. Okay. Echinococosis or hydratid. Okay, that's a type of parasite. Not something that you need to know for the pants, but it's kind of cool. Don't aspirate those. Okay, so if your radiologist says this looks like this, don't aspirate, send them to general surgery so that we can resect it surgically. You need to get it out completely as one big cyst. If you try to rupture it and try to aspirate it, the risk of actually them dying from a parasitic infection that's now intraperitoneal is not good. Okay? So if you see that on any type of image report, send to general surgery. Okay. Then you have the cisadenoma. These are pre-malignant. Okay, so these are the ones that are like, yeah, they're getting bigger. They're starting to become more painful. They're complex. They're going to have internal septae. So instead of it just being nice and round and smooth with the same coloring throughout, you're going to have actual lines. It'll look kind of like this guy up here. Okay, lines through it. It doesn't look nice. It doesn't look clean. Those are the ones that need to be surgically resected. Okay, those can actually be pre-malignant and need to be removed. Okay, so smooth, same consistency throughout. Most likely can just observe if asymptomatic. If symptomatic, send to general surgery. If it looks weird, send to general surgery. Okay. All right, polycystic liver disease. These people have just cysts all over the liver. Okay, it's an autosomal dominant condition. It's a gene mutation. Most patients are asymptomatic until you have hepatic insufficiency. Okay, You'll have abdominal distension, fullness, vague pain, early satiety. We can find it on ultrasound, CT, MRI. If you have a lot of cyst fenestration, it's type 1. So like less than 10 cysts with sizes around 10 centimeters or less, that's 1. Okay? If you get up to diffuse parenchymal involvement, that's a type 3. Most of the time they need to have a liver transplant. Okay? When you have diffuse parenchymal involvement, the liver just cannot keep up. They are probably in liver failure and they need to have a liver transplant. All right, hepatic hemangioma. Okay, so now we're into tumors, not cysts. So this is the most common tumor. Okay, this is a solid tissue tumor. Okay, it's a vascular malformation, so it's not cystic. Normally we find these incidentally. Okay, they go in to get a CT for something else, and we find it, or we're looking for an ultrasound for the gallbladder, and we see this cyst, or we see this mass, so then we send them for an MRI. These are ones that we absolutely do an MRI on. We can get sensitivity and specificity of up to 98% for a diagnosis. Okay? If it is asymptomatic, we just watch it. If they have severe pain, if they have compressive symptoms, portal hypertension, they have hemorrhaging, and we do not know if it's malignant or not, we go in and take it out. Okay. All right. So next we go into hepatic adenoma. Again, tissue mass. Okay. Hepatocellular adenoma, or HCA. We see these a lot in females who are on oral contraceptives and or anybody who's on androgen steroid use. Okay, so your question will be, you have a female of childbearing age on OCPs with a new liver mass. It's HCA. Okay, you'll have pain, you'll have abdominal fullness, you may have abnormal liver function tests, you may have some bleeding. Okay, if it's less than 3 centimeters, you stop the OCP and you observe. You watch it. Okay. If it's greater than 3, greater than 5, that's when we start to suspect malignant transformation. Okay, if it's rapidly growing, we most likely will take it out, along with stopping the HCP or OCP. Okay. If we do any nuclear studies, it'll be a cold nodule. Any MRIs, you'll actually lose the signal, so it'll get darker. Okay. But just remember, if it's a small adenoma, most likely it can be observed, but we watch it. You take ultrasounds every 3 to 6 months, stopping the OCP. Most of the time you stop the OCP and it goes away. Okay. If it doesn't, then that really means you really should go and get a complete surgical resection. Okay. All right. Focal nodular hyperplasia, FNH. Benign hepatocellular hyperplasia, okay, is benign. It basically means the tissue is like kind of overgrowing in this one area, okay? Most of the time it's managed non-operatively. Malignant potential is 0, okay? Minimal risk of rupture or bleeding. It's just the tissue is overproducing its own tissue and looking funny on imaging. Okay. A lot of times we just observe it. Most of the time it stays asymptomatic. Okay. Hepatocellular carcinoma. These are the first cancers, like first true cancer of the liver, right? Major risk factor for HCC is chronic liver disease. So anybody who has any hepatitis, okay, any chronic hepatitis, you have to be on the lookout for this. Do not miss it. Okay, you'll have the alcohol abuse, you'll have the non-alcoholic steatohepatitis, which is the fatty liver. You may have alpha-flocxin B1 exposure, A1 antitrypsin deficiency, hemochromatosis, you may have primary biliary cirrhosis. Like any of those are major risk factors, or risk factors, but chronic liver disease is the major risk factor. Okay? Early identification is crucial. Biopsy is required. Okay? To properly diagnose, we really either need a CT or MRI and a biopsy. For people who are at high risk, any of these people, you need an ultrasound with and without serum alpha fetoprotein testing every 6 months to be on the look for it. If it starts to look like it's going that way, then you need to send them to general surgery. Okay. Most of the time we can cure this. Surgical resection, transplant, we can ablate it if it's caught early enough. Okay. If we don't, there's other things, palliative options that we can do, but really I want you guys to know that if you catch it early enough, you can actually cure it. All right, metastatic liver tumors. So these are tumors in the liver that are not liver cancer. Okay, these are metastatic to the liver. Most commonly it's from the colorectal cancers. Okay. Colorectal cancer is the third most common diagnosed cancer. So mets to the liver is pretty common, about 40%. So anybody who has colorectal cancer, you have to be also looking at the liver to make sure that it doesn't mets there. Most of the time they're going to be asymptomatic. We can identify it CT, MRI, and PET scans. The only curative treatment is surgical resection. But it really depends on if it's symptomatic or not. We still try to take it out if they're well enough to undergo surgery. For untreated mets to the liver, survival is less than a year. If we get it and get all of it, 5-year survival rate goes up to about 50 to 60%. So this is why we remove them when we see them. Okay. Unfortunately, 70% of patients will develop a recurrence. So these are not one and done. If they have colorectal cancer or if they have a metastatic liver disease, you have to keep following up with them to make sure that we catch that recurrence and take it out when we see it, or ablate it or whatever. Okay. All right, going on to acute liver failure. So with acute liver failure, this is liver disease that develops within 8 weeks of initial onset. Okay, you'll have jaundice, you'll have encephalopathy, you'll have coagulopathy. You'll be coagulopathic. Okay, so basically your liver's shutting down, it's not working right. If you have encephalopathy within 2 weeks of onset of jaundice, then you're most likely in fulminant hepatic failure. Okay, fulminant liver failure is excruciating. Okay, it is very morbid. A lot of people do not live when we get into fulminant liver failure. Most of the time you need to have a transplant at that point or else you will not survive. Okay. So, acute liver failure, less than 8 weeks. If you develop encephalopathy within 2 weeks of jaundice, you get fulminant. Acetaminophen toxicity remains a primary method of this happening, of occurring, of cause for ALF. Okay? Which is why when we teach you the doses of acetaminophen, we stay less than 4 grams a day. Anything more than that has been proven to cause this. Alright. So, recognizable manifestations. You have the jaundice, you have encephalopathy. You could be in adult respiratory distress syndrome, multi-organ dysfunction syndrome, but most of the time if you have acute liver failure, you're going to be jaundiced. You may have encephalopathy. Okay, your liver enzymes are going to be through the roof. When you have fulminant, you're going to have massive liver necrosis. Your liver is dying. Okay, profound coagulopathy. You're going to be oozing. It's going to be hard to, their IVs are going to be oozing. They may have cerebral edema, they're going to have brain damage, they're most likely going to be in a coma at this point, and they're most likely going to die. Okay, so this is why we try to prevent this. So what can we do to try to figure out what's going on? So we use CBC, we want a platelet count, we want liver function test, coagulation profile, and we want to assess the renal function, right? You have that hepatorenal relationship. Once one goes, most of the time the other one goes. We have to keep that liver or the renal function in check. Okay, we want to know the toxicity screen. Did they do this to themselves, or did they accidentally overdose in Tylenol? And then any sepsis workup, we want blood and urine cultures. If there's ascites, okay, if they have that fluid wave, their belly is nice and exuberant, we want to do an analysis of that ascitic fluid to see whether it's malignant, like if there's anything in there that would help us determine the cause. And then we want to know serology testing for hepatitis. Okay, the full panel. Okay, we want to do a chest radiograph, and most of the time we'll do an MRI of the brain for that encephalopathic evaluation. We'll also do an pneumonia. And then we need to do a liver biopsy to figure out why it is failing. And we can test that tissue to see exactly what's going on. All right. The first kind of 4 bullets are pretty self-explanatory, right? If you have encephalopathy with rapidly deteriorating mental status, you need to protect the airway. Okay? Their ultra-mental status is so much they can't really participate in life. Most of the time you have to protect their airway. If they reduced urine output in a patient who's euvolemic, most likely means that they're impending renal failure. If they have elevated liver enzymes and an elevated INR, if increased bleeding concerns. Okay. If you have a slow rise in serum billy, most likely you're not going to have resolution. You're probably not going to get better. So, when we have to actually do liver resections, okay, if you have a normal liver function, up to 80% of your liver can be removed. If you're normal. If you have no underlying liver pathology, 80% of your liver parenchyma can be removed to be like auto-transplanted into someone else, or you can have 80% removed to remove a mass or whatever that may be. Okay, but you have to have normal liver functions. Any amount of abnormal liver functions really depends on how well that's tolerated. Okay, there really is no set number of, well, if you have this, then you're going to be able to remove this. Okay, it really depends on what class Q or Child-Pugh score you are, what your MELD score is. Okay, but if you have a Child-Pugh score of C, remember that's the worst one, most likely you are not eligible to have any of your liver removed. Surgical approaches really depend on the degree of chronic liver dysfunction. Okay. If you are in acute liver failure and you're really coagulopathic, we're probably not going to do an open surgery. We may actually then try to do some sort of staged event to try to do whatever we need to. Okay? And then if we need to, we'll put you on the transplant list to get a new liver. Alright, moving on to chronic liver disease. Okay? This is 8 weeks and longer. Okay? This is not new. This is long-standing, ongoing liver injury. Cirrhosis is an irreversible state of advanced liver fibrosis, grade 4. Okay, when you get to this stage, your liver cannot recover. Which is when you start having that portal hypertension. Okay, increased resistance to the portal venous blood flow within the liver. Okay, when you have your liver riddled with cysts or disease, the ability for that liver to function and to filter is not going to be there, right? So you're going to have a backup. So you're going to have ascites, you're going to have esophageal varices, you're going to have hemorrhoids. You may have caput medusa, which is this guy down here. Okay? Basically you're looking at the stomach and it's just, you see this whole network of like worms underneath their skin. It's crazy. Okay? You'll have jaundice, you'll have encephalopathy. Coagulopathic, increased risk of bleeding. You're going to have prolonged PT and INR, elevated INR. Could be localized minimal bleeding to life-threatening massive hemorrhage. It really just depends. Most of these people have poor nutrition, and people who have gallbladder disease most likely will be, associated with depleted levels of vitamin K, like we talked about. Okay. All right. So what do we do to treat liver disease when we can't take it out? So we do admission, resuscitation. We give them nutrition. Okay. We can do it in TIPS, which is a transcutaneous. That should not be transcutaneous. That is transjugular. Sorry. Not transcutaneous. Transjugular. It's still cutaneous, you still go through the skin, but you go through the jugular. Intrahepatic portosystemic shunt. Okay, so basically what this is we do this through the jugular, through the venous system. Okay, and we go through the liver and we basically make a shunt between the hepatic veins and the portal veins. Okay, this is an artificial shunt that connects those two to help relieve that pressure. I apologize, I'll fix that. Okay, so that's the TIPS. Anybody who has portal hypertension, we can do a TIPS on. Beta blockers may be used to prevent the first bleed. Okay. If they bleed, so if after their first bleed, okay, within the year they have a 70% mortality rate. Okay, so we try to prevent that. We try to make them abstain from alcohol, and if they have encephalopathy due to free ammonia, we give them lactulose. Okay. You see somebody on the floor or in the ICU on the lactulose, what's the major side effect? Anybody know? Anybody seen anybody on lactulose? So the way that lactulose works to get ammonia out of the system is basically pushing it into the gut, and so you have massive amounts of diarrhea. Okay, massive amounts of diarrhea. They will poop a lot. All right, Budd-Chiari syndrome. This is pretty rare, but something you need to be aware about. Okay. Unusual cause of acute liver failure. Basically, you have a thrombus in the hepatic vein acutely. Okay, it causes acute hepatic outflow obstruction. Mostly in women who are hypercoagulable. So women on OCPs, or women who smoke, or women who are sedentary and smoke, and on OCPs. Okay, you'll have acute onset of right upper quadrant pain, you'll have hepatomegaly, and you'll have ascites. Okay, normally the course is pretty benign, and the liver enzymes pretty normalize pretty properly once we fix it. We can find it on ultrasound or CT, and the biggest treatment is the anticoagulation initially. If we can, if their INRs are too bad, we anticoagulate them. We try to get that clot to break up. Okay. Otherwise, we do a TIPS. See, I got it right there. Transjugular intrahepatic portosystemic shunt. Okay. There are other types of portosystemic shunts, but I'm only going to make you learn the TIPS. Okay. Once portal decompression is done, well, we try to do portal decompression before massive hepatic necrosis occurs. Okay, we try to catch it before that liver dies. Again, once that hepatic necrosis really occurs, there's not much we can do. Then you're in fulminant hepatic failure, and liver transplant is the only option at that point. Okay, if their clot is so bad that their liver dies, can't get it back. All right, question for you. 53-year-old man presents with distended abdomen. Examination reveals a protuberant abdomen without specific point tenderness, so just diffused. Okay, a fluid wave is appreciated. I can't get anywhere close to the podium. Right upper quadrant percussion demonstrates hepatomegaly. There's yellowing of the skin, reddening of the palms, the proximal nail beds are rounded. Which of the following is most likely included in this patient's past medical history?
D.
Anybody not agree with D? Good. Alcohol use. All right. What time is it? Oh, we actually get through this pretty quick. Am I going too fast?
No.
Love it. Okay. Hepatobiliary terminology. So now we're going into the biliary tree. Okay? This is where it gets really confusing with a lot of words. And this slide will hopefully help you break up those words into what you should be looking for. Okay? Chole is bile or gall. Okay? Just think bile. Cholecyst is gallbladder. When you have cholecystitis, it's inflammation of that gallbladder. So that itis, okay, inflammation. So inflammation of the gallbladder. Okay. When you have ectomy, is removal. So cholecystectomy is gallbladder removal. When you have lithiasis, that means stones. So cholelithiasis is gallbladder stones. DOCO, common bile duct. DOCO, common bile duct. So when you have choledoco, really it just means the common bile duct to the gallbladder. Okay? When you have choledocholithiasis, that's a stone in the common bile duct. Okay? So if you break them down, you can kind of see they're maybe a little bit more easier, a little bit, to kind of wrap your head around. Okay? All right, some review. So you have the gallbladder, right? You have the cystic duct. You have the cystic artery that branches off the right hepatic artery. When we take the gallbladder, we have to make sure that we find that artery, or else you're going to have bleeding. Okay. Coming down, you have the common hepatic ducts coming down into the common bile duct. Okay, so you have the cystic duct, common hepatic ducts, common bile ducts. So the cystic duct and the common bile duct, cystic duct and the common hepatic duct combine to make the common bile duct. Okay, that goes through the pancreas, and then you have a little sphincter, so it meets up with the pancreatic duct, and you have a little sphincter, a sphincter of Oddi, okay, which has the pancreatic duct and the common bile duct coming together and exiting into the duodenum. Okay, all you guys remember this from anatomy like a year ago? Yeah, fun, right? Okay. So basically, those are the biggest things that I want you to take away from that. Okay, so what can we do to actually image and look at the bile ducts? Okay, ultrasound, first line. Anything right upper quadrant pain, do an ultrasound. Okay, if you see stones, you're going to see a hypoechoic. Okay, this one does not have any stones. I'll show you one in a little bit that has a stone. But normally you would see a shadowing, kind of think like, you know, the UFO with a light underneath it, kind of beams down. Okay, there's no shadow, there's no beam underneath the gallbladder, meaning there's no stones. Okay, you can look for gallbladder thickening. Okay, less than 3 millimeters is normal, so anything above 3 millimeters is not normal. Pericolic cyclic fluid is not normal. Okay, and then, yeah, these are not normal. These are abnormal. Abnormal signs. These are what you're looking for. Okay. And then sonographic Murphy sign. What do you think the sonographic Murphy sign is?
Push with the ultrasound.
It hurts when you put, like, if they stop breathing, and it hurts when you actually are looking and doing the ultrasound. Okay, just like if it was your fingers, but you're using the ultrasound instead of your fingers. Okay, can really differentiate between systematic cholelithiasis and acute cholecystitis, which we'll go through. All right. The next two are pretty similar. Okay. Endoscopic retrograde. I practiced this one. Cholangiopancreatic. Oh, I almost had it. Cholangiopancreatogram. ERCP. Okay. Endoscopic, meaning it's a tube with a camera down your throat. Okay. This is therapeutic. We can do therapeutic things with this. So it's also diagnostic and therapeutic. We can remove stones, we can do stricture stenting, we can do sphincterotomies, we can do a lot with that endoscope, okay? But it is a very specialized endoscopic procedure, so we need to get GI to do it. General surgeons probably, unless they've done this a lot, and most of the general surgeons don't really do ERCPs. This is very specialized, okay? So we need to get GI involved if we want to do an ERCP. But what we can do is actually look at the inside of the biliary tract. We can look inside the pancreatic ducts, and we can actually fluoroscopically, okay, with contrast, actually light up on fluoro, basically like what it looks like in real time. Okay, normally pretty safe, but it's not without risks. Pancreatitis is the #1 complication. Okay, we can cause that pneumobilia, we can cause bleeding. You know, just like with any other major procedure, we can cause cardiopulmonary events. Okay, so it's not without risks. So remember, ERCP, therapeutic. MRCP, magnetic resonance cholangiopancreatogram. MRCP. This is just a picture. Okay, this is in the MRI, not therapeutic. This is just to see what's going on. Okay, it is just a screening tool. We use it a lot, but it's just a screening tool. We cannot do anything with immediately like we can with the ERCP. Okay, we compare it with the abdominal ultrasound. It's sometimes equivalent to the ERCP and a cholangiogram, which we'll talk about. But again, it's just a screening tool. Like we see this stone, but we can't do anything about it. Now we either have to go in and do a cholecystectomy with an IOC, which we'll talk about, or we actually then have to do an ERCP to try to get that stone out. Say it's in the common bile duct. We want to get that stone out first before the surgery. So it's just an additional thing, okay? It is very expensive. It's not widely available, okay? Certain patients with implants, because it's an MRI, if the stone is less than 6 millimeters, it's very poor at detecting it, very time consuming, and again, not therapeutic. So they do have their instances in which we want to do that, right? If they're pregnant, we'll do an MRCP to make sure before we put them at risk of an ERCP or surgery. Okay, so there are specific instances in which we do an MRCP, but it has its pros and cons. Okay, everybody understand the difference between ERCP and MRCP? Any questions on that? Great. Okay, next we have the HIDA scan. This is a nuclear scan. It's a cholecystectomy. Well, there's supposed to be a space between scan and cholecystography. Okay, it's a radionucleotide. So historically, it's been used for cholecystectomy or for cholecystitis. Okay. More frequently, now we use it for biliary dyskinesia. We really don't talk about biliary dyskinesia. Basically, it's the gallbladder is not working. It's not functioning right. It's not contracting like we want to. So we use the CCK stimulation. We give them CCK with a drink, and then we measure their ejection fraction with a HIDA scan. Okay, I used a HIDA scan in numerous cases when I was in primary care. Chronic but occasional right upper quadrant pain. Ultrasounds don't really show anything. No stones, no fluid around the gallbladder, no wall thickening. Then we do the HIDA with the CCK, and we notice that their ejection fraction is like nil. Okay, great, their gallbladder's not working. Let's go send them to general surgery so they can get it out. Okay. The biggest thing is, so say you have a stone in your common bile duct. No. either your common bile duct or your cystic duct, okay? That contrast is gonna go through your hepatic ducts and into your common bile ducts and not into your gallbladder. So it does show you kind of where things could be if there's a stone, which is why it historically was used. There's more, this isn't really widely used in the US, but this is something that we could have used before IOCs and ERCPs were a thing. Okay? So when you think HIDA, think more so for biliary dyskinesia. Alright. Intraoperative cholangiography, IOC. A lot of times surgeons do this routinely now just to cover their butt to make sure that there's no stones within any of the biliary tree. Okay? So routinely, or if there's any suspicion for stones in the bile duct. So when they are in, they go and take the gallbladder out, and then they do a direct cannulation. They use a little tiny catheter, just like an IV. They stick it into either the cystic duct before they close it, or the common bile duct prior to ligation, okay? Or they can put it straight into the gallbladder before they take the gallbladder. They put contrast through and then do a fluorescein, or not fluorescein, basically a fluoro under, like, actively pushing, okay? So this is an active picture. We can see, so right here, right, we see contrast up until here, because there's a stone there. If it was no stone, you'd actually see where it entered the pancreas. A CBD or a common bile duct greater than 10, or about 10 is way too big, okay? So that is a dilated duct. So this one, we're either gonna try to flush it, try to get that stone to go through the sphincter, or we can use glucagon to try to release, to relax that sphincter of Oddi to get that stone to pass. If not, sometimes what we'll do is do an ERCP directly after to do a sphincterotomy. We won't necessarily inject air up into the system, but we can do a sphincterotomy to try to release that sphincter of Oddi to get that stone out. Okay, if we don't remove that stone, what we just did with the cholecystectomy did absolutely nothing. Okay? It will not reduce their symptoms or relieve their symptoms at all if we don't get that stone out. Okay? Why is this important? So every IOC, the current data shows that with the IOCs, 2 to 10% of patients will have a common bile duct stone, of which 10% were not suspected perioperatively. Okay, so before they went to the OR, they did not suspect a stone. They did an IOC, and a lot of them actually showed a stone, which is why most surgeons are actually moving to do this routinely now, versus not just for suspicion of or suspicion of stones. Okay, if you get to see this in the OR, it's pretty cool. It's fun. You get to see this big C-arm in the OR suite. It's fun. Okay. All right. So, in terms of choledochal lithiasis, okay, you use lab and ultrasound results to kind of stratify the risk of that patient. Okay, if they are low risk, we just do cholecystectomy. If there's stones or sludge on the ultrasound, they're intermediate risk, so about 10 to 50% of risk of a CBD stone. Then we most likely will do an MRCP or an ERCP or a endoscopic ultrasound, depending on availability. If they are high risk, we'll do an ERCP with stone retrieval before we do the cholecystectomy. Okay, so intermediate and high risk are kind of, if they're high, we absolutely do the ERCP. If they're intermediate, that's kind of where that gray zone is. Well, we can do ERCP, we can do an MRCP. MRCP doesn't cause pancreatitis. Right, so if they're already at risk for high rate of pancreatitis, then we'll do an MRCP. If not, then we'll just do the ERCP, and if there's a stone, we'll retrieve it. All right, I would know this. It is a very good outline of like kind of what would happen. Okay, I'm not going to test specifically from this, but it is a very good outline of what we would do. All right, getting into, let's see what time it is. Oh, let's take a 10-minute break. Come back at 9 o'clock, please. So we're gonna get into gallbladder disease, okay? This is where it kind of gets a little more confusing, so try to pay attention. All right, so cholelithiasis, gallbladder stones. Okay, estimated 10 to 50% of the population have this. It is cholecystectomies is the most commonly performed elective surgery in the U.S. Okay. So major risk factors: over the age of 40, female, obese or fat, flatulent, and fertile. Those are your 5 F's. Remember that from GI? 40, female, fat, flatulent, fertile. Okay, those are your major risk factors for gallstones. Okay, it occurs when substrates of the bile precipitate out. Okay. There's 4 major causes, or 4 major types of stones. The biggest one is cholesterol. Okay, bile becomes supersaturated with cholesterol, and basically it just causes a stone 80% of the time. You have pigment stones in the setting of hemolysis. You have bilirubin stones, and you have calcium stones. Okay, I'm not going to make you know the pathophysiology of how those things happen. Just know that there are 4 different types of stones. Okay. All right. So, asymptomatic cholelithiasis. You have stones in your gallbladder, but it's not causing you issues. Okay. 10 to 20% of all Americans will develop cholelithiasis. Okay. A lot of us will never develop stones. You don't really know you have stones until they become a problem. Most are found on incidental abdominal ultrasounds, liver ultrasounds. Okay. Pretty low complication rate, 1 to 4%. Because of that, prophylactic cholecystectomies is not justified. Okay. So if the patient is asymptomatic, not having any problems whatsoever, we're not going to take the gallbladder just because. All right. Which of the following is the least likely component of gallstones? What do you think? Anybody want 1, 2, 3, 4? Oh. Triglycerides. Least likely. So we have calcium, we have calcium. Sorry, cholesterol, bili, and calcium. Those are 3 major stones. The pigmented ones from the hemolysis are the 4th type. Okay? All right. Now what happens when it becomes symptomatic? Okay, a lot of people call it chronic cystitis or chronic cholecystitis, biliary colic, but it's basically symptomatic cholelithiasis. It's transient, colicky, right upper quadrant pain. It is not constant. It is colicky. It comes and goes most frequently after a high-fat meal. Okay, it can be with any meal, but mainly high-fat meals really makes the gallbladder work harder, trying to push against those stones, making it painful. Okay, nausea, vomiting can occur if the episodes start to increase in both frequency and intensity over time. That's when we normally get referrals to general surgery to try and take the gallbladder out. Okay, if the episode has resolved, their physical exam is going to be completely normal. They won't have a Murphy sign. They won't have belly pain. They're not going to be nauseous or vomiting. Okay, their physical exam will be completely normal if the episode has resolved. But once you start to have symptoms, complications, and recurrent pain are only going to get worse. Okay, only going to come more frequently, increase in pain. Okay, your complication rate is going to go up. Okay, so how do we find it? Ultrasound modality or imaging modality of choice. Okay, you're going to see hypoechoic acoustic shadowing. This is what I was talking about. Okay, you have that stone in the gallbladder, you have that UFO type sign, you know, the beam of light but beam of dark. underneath it. Basically, the waves of the ultrasound cannot get through that stone, therefore it distorts the rest of the image further into the body. Okay? They may be mobile, okay? They may move around in the patient. If they're at low risk for choledocholithiasis, no other additional imaging or testing is needed prior to the cholecystectomy. We can still do an ERCP, MRCP, and IOC for any intermediate or high risk if we think for choledoco. Like I said, for IOC, most of the time it's now becoming routine with surgeons. Just depends on the surgeon, but most of them are going to routinely doing IOCs because the risk of missing a stone in the common bile duct is pretty, not great. If we can do it during the surgery, it prevents further complications for the patient. Okay. So what makes it kind of intermediate? Anybody with hyperbilirubinemia. Okay, so if they have episodes of pain, and we actually get them in an episode of pain, we get their enzymes and their bilirubin is high, suggests a transient episode of a choledocholithiasis. Okay? That's intermediate and high risk. Okay, if you have any change in bilirubin elevation, we should suspect a common bile duct stone, so we need to do either an ERCP, MRCP, or an IOC. Okay. All right. If you have symptomatic choledocholithiasis, do you get a cholecystectomy? If it's symptomatic, we take it out. Okay? Because, like I just said, once you start having pain and symptoms, your pain and symptoms are only going to get more frequent and worse the longer we go. Okay? There are some non-operative treatments, not very effective, not really used. A lot of surgeons will kind of balk at it because it's like, I'd just rather would take out the stone. But if there are candidates who cannot take the stone, or they have very small stones, okay, there's we can actually do lithotripsy on those stones. Okay, I'm not going to make you know what that ESWL is. It's basically lithotripsy for gallstones. And try to break up those stones. We have an oral solution that we can give them, but again, we really only do this for surgical candidates and not very widely used. Okay, so take out the gallbladder. All right. So now we're moving into acute cholecystitis. Okay, so you had a gallbladder that had stones and it was causing pain, but it was not infected. It was not really inflamed. Okay. Now with cholecystitis, you have occlusion of the cystic duct by gallstones, you have an inflammatory response. Okay, you're going to have ischemic necrosis or perforation from that obstruction. Okay. So 10 to 20% of systematic cholecystititis will develop acute cholecystitis. So that's why we take them out early to try to prevent acute cholecystitis. Okay, so this is when you have unremitting pain that lasts for hours to even days. These aren't the acute 30-minute attacks. These are, the pain never goes away. You have right upper quadrant pain, you are sick. You are vomiting, you can't keep anything down, you may even have a fever, lack of appetite, you have a positive Murphy sign, okay? So that gallstone has gotten stuck somewhere and it is now causing infection within the gallbladder. Okay? You're going to have a mild leukocytosis, 12 to 15. Some will have a normal white count depending on where they are in their progression. Okay? If you have an extremely white count, 20 or above, you might actually be getting into the realm of cholangitis and or gangrenous cholecystitis. Okay? So we try to catch it early. This is where you start to have alkaline phosphatase, your transaminases, and your bilirubin, mild elevations. Okay, mild. Not going to be crazy, but it's not going to be like just above a little over normal. It'll be elevated, but not like in the liver failure yet. Okay. All right, diagnosis, again, ultrasound. Most effective, easiest way to do it. We'll see all of those signs. You'll have the thickened gallbladder wall, you'll have the pericholecystic fluid, you'll have distension of the gallbladder, you'll have that sonographic Murphy sign. Okay. If the ultrasound really doesn't show it, then we can do a HIDA, but again, most of the time we can see it on ultrasound. Okay. We really don't do CTs or MRIs anymore. They're just not that great for it. Okay, so ultrasound is our first line. Alright, so what do we do for acute cholecystitis? We have to make them MPO. We have to start IV hydration, broad spectrum antibiotics. Okay? What do you think we want to do? Broad spectrum. Which ones? I heard Flagyl, Cimetronidazole, and Cipro. Yes, it's within the GI tract. Okay? Polymicrobial. Ciproflagyl. Kind of gave you a hint up here in the corner. Ciproflagyl. Okay, IV. But the definitive management is a laparoscopic cholecystitis, or cholecystectomy. Okay? We will always try to do it laparoscopically. We can always convert to an open, which is very morbid. Basically, we cut from the diaphragm or from the xiphoid over to about the either mid-axillary line or inter-axillary line. It's a big, huge cut. I've only seen it once. Okay. But most of the time we do it laparoscopically. We try to do it within 72 hours of the symptoms starting. So this is an urgent case. Okay. If the candidates are not suitable for operations, what we can do is relieve that pressure. Okay, so we basically do a percutaneous, so through their side, mainly probably from the front or the side. IR will place a drain, most likely under CT guidance, into the gallbladder. Okay, so percutaneous cholecystotomy. Cholecystotomy. So like a chest tube, but a gallbladder tube. Okay. Basically what that does is, because that cystic duct is, or wherever in the duct is blocked, okay, as another way for the fluid and the infection in the gallbladder to be relieved. Okay, it's going up through the skin into a drain bag versus down the normal tubes. Okay, once that patient gets better, if we can get them better, then we will go in and actually remove the gallbladder at a later time. Okay, but in those patients who are truly septic and they cannot go and do an actual surgery, that the risks are too high, we will do a percutaneous drain into the gallbladder to relieve their symptoms. Okay, which of the following is the most appropriate treatment for uncomplicated acute cholecystitis? I'm hearing 3. Anybody disagree with 3? Anybody have any other thoughts other than 3? Right, so IV antibiotics and surgery within 72 hours. Okay. All right. What if you have cholecystitis without a stone? So acalculous cholecystitis. Okay. Pretty rare. Only 5 to 10% of patients with acute cholecystitis will be acalculous. Most of the time, it'll be in our critical care patients. Okay, these are ICU level patients who are polytraumas. They have large surface burns. They've gone on long-term parenteral nutrition, okay? Major operations. These people are already sick, okay? They've been in the ICU for a minute. They are already critically ill. The gallbladder sometimes has a hard time catching up, okay? So what we do, so you have biliary stasis because you're really not eating, you're on TBN, you have kind of translocation of like E. coli, salmonella, all of the things. Like the sick people just, their gallbladders go bad, okay? Complications are far more common and far more like acutely, okay? Gangrene is the most common. They can perforate. It just, it's not good. The gallbladder gets very, very sick. So if they are poor surgical candidates because they're critically ill, we will do that too, a PCT tube, okay? If we can get them into the OR, then we'll take their gallbladder out. We'll do an early laparoscopic cholecystectomy. Most of the time these patients are too sick to even go to the OR, so they get the tube, and then once we get them over their critical illness, then we go back and take the gallbladder out, okay? But these are for people who do not have stones. They're already sick. All right, the fun one, choledocholithiasis. Try saying that 5 times fast. So, stone in the common bile duct. Okay? You have 2 different types. Primary, the stone originates from the biliary tree. Most of the time they're brown stones. Secondary choledocholithiasis is it migrates from the gallbladder. Okay? So we have conditions in which stones can actually develop within our bile or in our biliary tree. Otherwise, it migrates to the CBD from the gallbladder. Okay? Most of the time, these stones are pretty small, and we don't really realize they're asymptomatic. It's only when they become large enough that really causes problems. But most of the time, they're asymptomatic. Okay, 10 to 20% of people undergoing laparoscopic cholecystectomy if we just find it. So what do we look for? Abdominal pain that radiates to the back, jaundice. This is where our first jaundice comes in. Okay, nausea. You're going to have acolic stool, so they're going to be pale white, gray, or clay colored. And dark urine. Okay, so in all the other ones, this is the first time that we start to see jaundice, okay? Because now we have no way of getting that bile to, like it's really bad where it can't get any bile out. Okay. So with choledocholithiasis, leading to cholangitis. Okay, we have Charcot's triad. Okay, I would remember Charcot's triad. Okay, you have right upper quadrant pain, fever, and jaundice. Okay, if you have right upper quadrant pain, fever, and jaundice, think choledocholithiasis. Okay. Choledocholithiasis is one of the leading causes of pancreatitis. Okay. If that stone is far enough down where the pancreatic duct can't release its enzymes into the duodenum, then the pancreas is going to get pissed off. Okay, so it's the leading cause of pancreatitis. And that's where you start having that severe epigastric pain that radiates to the back. All right, so what do we see in laboratory results? We have a leukocytosis, so 15 to 20. And even above 20, pretty common. Okay, this is where you have that rise in serum bili. Okay, normally stays under 10, only about 2 to 4. Okay. What's the normal range for bili? Around 1. Around 1 is the normal. Like every. Oh, sure. Yeah, around 1. So we really want bilirubin to be less than 1, around 1, okay? A few little points up and down, everybody's a little different, but around 1, okay? So once you get up into the 2s, above the 4s, that's when you really start to have a serious issue as to like why that bilirubin is high. You have to do some investigation, okay? You have serum alk phos again, and then mild increases in AST and ALT. Okay, so pretty similar to which one? We go back. Acute cholecystitis, you have mild elevations in alk phos, transaminases, and bilirubin, but your white count's not as high, and you're not jaundiced. Okay, once you have that jaundice, that's really when you start looking into choledoco. Okay. All right. Again, ultrasound, abdominal ultrasound, modality of choice. If you see a common bile duct dilation above 10 millimeters, it is pretty pathognomonic of choledocholithiasis. Okay. This is where we do the ERCP first. So if you do that ultrasound and you have a common bile duct dilation, you have jaundice, you have fever, you have, your elevations of your alk phos, your ALT, AST, your bilirubin, okay? Do an ERCP first. Look for that stone, look for that whatever, okay? It's called diagnostic and therapeutic. If we need to, we can do an MRCP, but again, most of the time we're going to do an ERCP. Okay, and most of the time we will not do an endoscopic ultrasound because we're just gonna, we want those tools in order to remove that stone or open that sphincter if we need to. Oh my, okay. Alright, just one. There we go. Alright, so treatment, what are we gonna do? So choledoco will lead to cholangitis, okay, which is the worst part of gallbladder disease. So you may have someone who has mild cholangitis and evidence of stones. We want to control the attack 24 to 48 hours with antibiotics. If we need to, we'll do that endoscopic sphincterotomy and or surgery. But most of the time, while we're giving those antibiotics, we're doing that ERCP. Okay. It will end in a laparoscopic cholecystectomy. If we do that, we will still do an intraoperative cholangiogram or IOC to make sure that all of the stones are out. Okay. If it can't go laparoscopically, like I said, we're going to do that ERCP. Another way to take this too is if that stone cannot be removed laparoscopically with the IOC, we just can't get it to go post-operatively, we will do the ERCP and do a sphincterotomy in order to get that stone out from the other way. Okay? Alright. So, treatment algorithm, you're going to be over the age of 55, the bilirubin is going to be over 1.7 or 2. Bile duct is going to be greater than 6. Okay, if it's greater than 10, pretty pathognomonic, you'll have a visible stone. Okay, so if you have these things, plus jaundice, plus fever, you're going to do ERCP, then laparoscopic cholecystectomy. Alright, cholangitis. This is the last line, the worst of the gallbladder diseases, okay, besides cancer. So, cholangitis, okay? Now we have an infection that is in the biliary ducts. Okay? You have significant biliary obstruction. Principal causes, choledocholithiasis, biliary stricture, and cancer. Okay. You have other different causes, but those are your primary causes. So obstruction, right, leads to ductal pressure rises, okay? You have bacteria that proliferates, and you become septic. With these, you're going to have that Charcot's triad, so biliary, colic, jaundice, and fever, but you're also going to have hypotension and altered mental status, which is Raynaud's pentad. Okay? So when you have those 5 symptoms, that's Raynaud's pentad, and you most likely have cholangitis. Okay? You're going to have leukocytosis. You're going to have elevated bili, elevated out phos. Okay? On the abdomen, you're going to have dilated biliary ducts. Your pancreatic duct may be high, may be elevated or dilated as well. Okay? We need to get this under control before we do any other investigation like ERCP. Okay? If we start shooting dye up into an infected biliary tree, then we could spread that to the liver and make them worse. Okay? So we try to get the acute manifestations under control if we can, and then do the ERCP to figure out where that infection is coming from, whether it's a neoplasm or what. Okay? Most cholangitis cases are controlled with IV antibiotics. Once we control it, then we do the ERCP. Ciproflagyl. If we have severe cholangitis, unremittent cholangitis, and antibiotic therapy is not working, then we can do that transhepatic drainage. I would do that drainage to the gallbladder or through the skin. Okay? Or we can drain it through. There's a couple different drainage things, but we can drain that system. Okay. Definitive treatment really is that ERCP, sphincterotomy. Okay. If unsuccessful, then we'll go to laparotomy and do some things. I know this is the hardest one to try to like figure out the algorithm of which one goes which, but it really depends on the patient. It really depends on whether there's a stone or not, whether it's caused by neoplasm or not, whether it's caused by being critically ill. Okay. Once you have that infection in the gallbladder, it can translocate to the biliary tree very quickly. So it really just depends on where they are and what we think is the best thing to do at this point. But realistically, antibiotics, ERCP, and or drainage, and then laparotomy if we can't get it under control otherwise. Okay. Any questions on cholangitis and how to differentiate it? Okay. The next 2 slides are just some really quick, one or actually 2 things per slide of what you should be looking for. Okay, so cholelithiasis, stone formation, colicky pain, works with fatty foods. You diagnose it with a right upper quadrant ultrasound, and it's an elective cholecystectomy. Okay, they're not sick, they're just in pain. Colicky pain comes and goes. Okay, cholecystitis, you have cystic duct obstruction. You have a positive Murphy sign. They have fever, they have leukocytosis, you're going to find it on the right upper quadrant ultrasound and or HIDA scan, and then you do cholecystectomy. Okay. You have the cholejocholithiasis, okay? This is where the common bile duct is obstructed. You have proximal inflammation, obstructive jaundice, dilated hepatic bile ducts, you do an ERCP. Cholangitis, you have choledocholithiasis plus infection. You have Charcot's triad, you have Raynaud's pentad. You're going to diagnose it with the right upper quadrant, and it's an emergent ERCP with IV antibiotics. Okay. Hopefully that makes it a little easier. All right. So you have a 52-year-old female complains of 8-hour history of nausea, right upper quadrant pain. She has no significant pathological history. The patient has a low-grade fever. Rebound tenderness in the right upper quadrant. There's no evidence of clinical jaundice. White blood cell count is 11. Liver function is normal. Urinalysis is normal. Which of the following is most likely diagnosis? Who do you think? 1, 2, 3, 4. Good. It's 2. Acute cholecystitis. What would we see with ascending cholangitis or acute cholangitis? You're going to have jaundice, right? You're going to have fever. You're going to have a white count probably greater than 20. Your liver function is not going to be normal. Okay? Your urinalysis is probably not going to be normal. You're probably going to have some dark urine. Okay? All right. How do we do a cholecystectomy? Okay, indications, those are just 4 of the indications. The symptomatic cholelithiasis, cholecystitis, cholangitis, and cholangiocarcinoma, which we are not going to talk about. Okay, cholangiocarcinoma is just most likely adenocarcinoma of the gallbladder. Okay, it's cancer of the gallbladder. Okay. Techniques, we have open laparoscopic. Laparoscopic is becoming the #1 choice, with conversion to open if there are signs that we need to be open. We will not normally search with open. Okay. We use about four ports. Okay, we have 1 in the belly or at the belly button. We have 2 in the right upper quadrant, 1 in the left upper quadrant, so that we can kind of both see everything. Okay, still inflate with CO2. And we do the Coker's incision. That's the when we do the open. So basically from xiphoid to basically the anterior axillary line, and that's called a Coker's incision. Okay, it basically follows the ribs down so that we can see into that gallbladder fossa. Okay. When you are doing a cholecystectomy, okay, if you know these, you will very much impress your surgeon. Okay? You may be on a test because it's so important. Okay? Certain surgeries will have a critical view of safety. Okay? This is a standard term in surgery that if there are certain views that a surgeon needs to have, critical views that need to be obtained prior to clamping, ligating, cutting any duct or vessel. Okay? A lot of times, if they're a newer surgeon, they may actually take a picture laparoscopically to show in their notes, I got that critical view of safety. Okay? They can see around the gallbladder, the cystic duct. They can see the common hepatic duct, and they can see the cystic artery. Because the last thing you want to do is cut the common bile duct or the common hepatic duct instead of the cystic duct. Okay? That is a huge litigation issue. Okay? We are trying to get the cystic duct. So we need to identify where the hepatic duct and the common bile ducts are. If we don't see that, then we can't definitively say that we are cutting the cystic duct. Does that make sense? Okay? So, triangle of Collot is those 3 structures that we need to see. Well, it should be including the common bile duct. But if we see the common hepatic duct, we can follow it down for the common bile duct. Okay? But they want to know where the cystic duct is, they want to know where the common hepatic duct is, and they want to know where the cystic artery is. When those 3 things are found, then they can say that they have a critical view of safety. Okay? If you know this, your surgeon will be very impressed. I would probably know this for the best. Okay? If we were to cut those other 2 things, the common bile duct and the common hepatic, it leads to devastating injuries, devastating complications, a lot more surgeries. Okay? It does not do the patient well if we cut those instead. All right. This is a kind of a more detailed view or list of what we do for a laparoscopic cholecystectomy. Do I have time to go through it? A couple minutes. Okay. So when we're in, we identify the gallbladder. Okay. We identify that critical view. Okay. We have the common cystic duct, we have that cystic artery, and then over there would be the hepatic duct going into the liver. Okay? It's kind of hard to see in that picture, but they look all around at different angles, which is why they have 3 different ports. Just because that camera starts at the umbilicus doesn't mean we can't put that camera in any other port and look at any other view. Okay? So we want to dissect the cystic duct and cystic artery out. Okay? When we do that, when we find that critical view of safety, we clip the cystic artery on both sides. Normally we do 2 clips to the patient side. We only need 1 to the gallbladder side because we're taking the gallbladder out. Okay? We clip the cystic duct. We divide them. Again, 2 clips. If it's staying in the patient, they normally do 2 clips on that tube, whether it's a vessel or the duct. Okay? Just to make sure that it stays clipped. We divide them sharply with scissors. Okay? When it says liberate, we are basically cauterizing the liver as we scrape the gallbladder off the liver. It's not great. It takes some time. Okay, the liver can bleed, but we're scraping it off of that gallbladder, within the gallbladder fossa. Okay, we remove that gallbladder. We try to keep it all whole. We do not want to spill bile into the belly, although it happens a lot. But we try to take that out. Okay, all in one. We send everything to pathology for tissue diagnosis. Okay, always send everything that we remove to pathology because we never know when cancer is there. Sometimes you can't see it. Okay, we get that, like I said, we document that we had that critical view of safety before anything was clipped or divided. If we need to do the intraoperative cholangiogram, okay, we have that cystic duct. Sometimes before they clip it, or maybe they'll only do 1 clip and then they'll try to thread a catheter either in the opening or they'll do like a little IV puncture into it like you see here. Okay, they put that cannula into the common bile duct and shoot dye, take pictures here to make sure that everything is open, that there's no stones. If there's a stone, then we do what we talked about earlier. Okay. But that's once we get the gallbladder out, then we take everything out, let the air out of the belly, close up the sites. Again, with the belly button, because it's a 10 to 12 millimeter port, we close that with sutures on the fascia and then the skin. For the other 5 millimeter ports, we just close the skin. Okay. What are the complications? Like with any surgery, bleeding. Again, if your cystic artery gets clipped and it's not, or gets cut and it's not clipped appropriately, it can bleed. The liver bled can absolutely bleed. Okay. If you accidentally clip the common hepatic artery or the portal vein, those absolutely will bleed. Okay. Injuries to surrounding structures is the most common complication, which we try very, very hard to not do. Well, I wouldn't say it's the most common. It is the most devastating when you have injuries to surrounding structures. Okay? So we try to not do that. Retained stones, you have infection, you have bile leak, you have incisional hernias, and then strictures. So anytime you touch something just like the gut, right, anytime you do anything, if their cystic duct is really short and you have to clip pretty close to the common bile, that may start an inflammatory process and cause stricture. Should be surgically repaired, or we can do a stent. It's pretty rare. Okay. Percutaneous gallbladder drainage, like I talked about, if surgery is a poor option, we do a cholecystectomy too. Okay. Place to decompress the bladder, normally done at bedside under ultrasound guidance or in IR under CT guidance, depending on how sick they are. Should show improvement pretty quick, 24 to 48 hours. Okay, if they don't, we want to do what we call a kind of like a drainogram. It sounds weird, but we basically put contrast up the drain and look at what it looks like and make sure that that drain is actually doing what we want it to do and it's still in the same place where we want it to be. Okay. And then that tube should stay in place until the patient is fully resolved, fully recovered. And then we can go to the OR and do a cholecystectomy. Okay. All right. When they're on the floor, okay. Initially, they're MPO, so we want to advance their diet as tolerated. We try to start them off with a low-fat diet, okay, but until they start having symptoms with fatty foods again, which is the most common complication, patient symptom-wise, we normally just let them eat whatever they want. Okay, we follow that leukocytosis if they had cholecystitis, cholangitis. Okay, we follow their electrolytes daily. We replete as necessary. We probably will do the IV antibiotics until they're afebrile and the leukocytosis is normalized. We'll start DVT prophylaxis, but we'll also ambulate them as soon as possible. IS and deep breathing. Okay, pain control, and then discharge criteria. They follow up within a week to 2 weeks in the general surgery clinic. We want to evaluate their incision and healing time, and then they can go back to normal activity within 6 to 8 weeks. Okay, so we limit the abdominal type exercises, no crunches, no pull-ups, no push-ups, no planks for a good 6 to 8 weeks. Okay. All right, so primary care responsibilities, not that many. It's mainly recognizing, okay? Anytime you have a patient follow up with any imaging, make sure you go through it. Make sure that they don't have an incidental loma, a liver cyst, a liver mass, something that you may need to help follow up on. Okay, if there's any signs of liver injury, liver failure, any liver masses, cysts, refer to GI as early as possible. Okay. For gallbladder, if it looks like cholecystitis, but symptoms are infrequent or no stones, make sure you do a HIA scan. Okay. Complications commonly following cholecystectomy, like I said, the gut really can't handle those fatty foods still. Before they couldn't handle it because their gallbladder wasn't working, but now we took their gallbladder, so they still cannot really handle fatty foods. So they're going to have stomach cramps, diarrhea, almost mimics a dumping syndrome within like 30 minutes of eating a fatty, greasy meal. They'll have that dumping syndrome type picture. Okay. It will go away with time. Or if it doesn't, then it's just more dietary precautions. You just tell them, don't eat that super greasy cheeseburger. Or know that if you eat that super greasy cheeseburger, you should probably be in your bathroom. So it's all, what the patient can tolerate. Refer to general surgery for any symptoms consistent with coli, whatever symptoms. Okay? If you think that they are sick, send to the ER. Okay. But if they're cholelithiasis, if you think they have chronic or symptomatic cholelithiasis, they have acute cholecystitis. For anything acute cholecystitis and above, I would probably just send to the ER if they're in an actual episode. If they're not in an episode and they just show up to your primary care clinic, you can most likely just refer them to general surgery with the caveat of having them, say, hey, if the symptoms happen, if your symptoms don't go away, if you start having fevers, if you start having a yellow tint to your skin, please go to the ER. So ER precautions, okay? Making it very clear to the patient that, hey, right now your symptoms look like this, we're gonna refer you to general surgery for them to take a look. But if you start having any of these signs, the bad signs, the red flag signs, you need to go to the ERs, so that you don't die. All right. Talked about a lot today. Any questions?